physical therapy is also a revenue generator for health systems. The nice thing about developing a cancer rehabilitation program is it doesn't require any new capital or equipment, because most of everything that you're going to need already exists if you already have an existing PT department, and 99.9% of hospitals are going to have that. So, treadmills, weights, treatment tables, exam rooms, those kinds of things already are in existence. And you can typically use existing staff. You don't necessarily need to bring in somebody from the outside to create a new FTE or something. Most of the time, what departments will do is they'll, pick someone who's interested in doing this kind of population, and then the cost will be educating that particular therapist on how to do this. So some continuing education cost. But the other nice thing for the cancer center is they don't have to pay the physical therapist, occupational therapist, or speech therapist. The rehab department pays them. So it really is no extra cost to the cancer center at all. And then, as I mentioned, the cancellation no-show rates for the cancer rehab populations are historically much lower than our folks who have orthopedics issues or, stroke or whatever. The capital investment will be pretty small, and that's going to be focused on educating and training the rehab staff and how to care for a patient. But you're talking several $1,000s at the most to begin a program. So all the pieces are there. It's just a matter of educating your therapist and your therapy team. And again, rehabilitation is third-party reimbursed, no differently than if your patient had a stroke or a knee replacement or a car accident or a work injury, based on geographic location, what kind of clinic it is. But on average, and again, reimbursement rates are all over the board, anywhere from 12 cents on the dollar to up to 57 cents on the dollar. But in general, a physical therapist will bill about $20,000 to $50,000 per month. And again, the payer mixes, need to be looked at geographically. But on average, if you threw everybody in a bucket, we get about 45% back of what we bill. So even at 4 patients a day, you're already beginning to make money. So in general, my people will say it takes about 2 to 3 patients a day to break even. So 4 or beyond, you're already getting a return on investment. So you're going to make up that education cost. You're going to make that up really very, very quickly. And all the stuff that you and I have already talked about have significant impact on when value-based care comes to oncology, because our orthopedic colleagues figured this out already a decade ago. And it's amazing how closely rehabilitation therapists work with our orthopedic docs now. They are getting people out of bed so fast now. Physical therapists are going into the recovery, the post-op recovery. They're strapping people's legs that are numb and standing them up because it gets them out of the hospital faster. It's just amazing. They've even pulled in the anesthesiologists and said, you can't have the patients throwing up on the physical therapist. So you've got to change the meds or give them better antiemetics or something. So it's amazing. So we can learn a lot from them because they've been forced into this model much sooner than we have. Physical therapists or rehab therapists will do what we call outcome measures. So we give the patient usually a 1-page questionnaire on how well are you functioning right now, whether it's balance or pain or shoulder movement or neck motion or whatever it is. And then we'll give them that same form then to fill out when that plan of care is finished. Okay. And then we take that percent of improvement and then divide that by how many times did we see that patient. And then that's kind of our percentage of, okay, this is how valuable. So every time Mr. Smith came in for care after his head and neck surgery, he got 11% improvement. And that's a really powerful number to be able to take back to administrators and say, look at how we're positively impacting care. And then I encourage cancer centers to, take easy data like cancellation no-show rates. Look at, how many people, that went to the ED within 30 days of a chemotherapy. What were they going there for? And are we seeing, one of the huge top ones is always deconditioning. That always ends up top on the list. And can we get that out of the top 5 by getting people exercising regularly? So there is a place for rehabilitation, decreasing the cost of care to get our patient from point A to point B, not only healthier, but also less expensively. So to wrap this up, Jay, what I want to do is just throw one slide here on first of all, on what a comprehensive cancer rehab program should look like, and then the 4 things that you need to start a program if somebody watching wants to do that. First of all, a cancer rehab program should be comprehensive. It should see all types of cancer, not just breast. And again, we want a program that sees people from peri-diagnosis all the way into survivorship, so they're following through that entire circle of care. And then treating all musculoskeletal, cardiopulmonary, and functional impairments that the patient has, not just lymphedema, or not just postoperatively. So we have to deal with all the crap that happens postoperatively, all the stuff that may happen during chemotherapy, all the stuff that can happen during radiation and after, and all the stuff that happens in survivorship. That's all under our window. So we don't want our physical therapists just seeing patients once postoperatively. That's not going to be a good comprehensive care that's going to support that patient through their trajectory. We want our physical therapists to be involved in multidisciplinary conferences, tumor conferences, just to answer questions, to provide support on, okay, like the last question I had for my medical oncologist was, hey, how do I know if this person is having balance issues because they have neuropathy or because it might be a brain mets? How do I figure that out? And there's always the debate of, do I do an axillary dissection? And then I can throw in, is what's the person's body mass index? How active are they? What is their actual risk for lymphedema? So just helping them make better decisions. Or if this guy's 88 years old and I have to do a full Whipple on him, what are the chances he's ever going to go home again? Or if I have to remove this person's esophagus, what are the chances that I'll ever get them to swallow again? And that's going to be best answered by a rehab therapist. And then again, your program should be collecting metrics on the value of care, quality of care, and then obviously patient satisfaction. We want to know that our therapists are making people happy. Finally, Jay, the 4 things I suggest cancer programs have to start there, what you absolutely have to have. And again, most people are going to have this, is you have to have patients with cancer. Well, you probably already have that. You need to have a referring source, whether that's a physician, nurse practitioner, or a PA. And again, that can be anywhere on the medical side, whether it's surgery, radiation, chemotherapy. You need to have a rehab therapist or therapists. And then you need to have a rehab treatment space. Most cancer centers are associated with some type of hospital or close to, even if it's independent. And it can be, again, if you are an independent medical oncology clinic, you can have an independent PT practice. It doesn't matter. If you write a prescription for physical therapy, a patient can take that wherever they want. Okay, they don't have to go. If you work at Hospital A, the patient does not have to go to Hospital A for their rehab. Now, it might be reimbursed differently if it's out of network or something, but that prescription is viable anywhere. Because most places, these pieces are already integral or already exist. So it's just a matter of educating your medical oncology side and your rehabilitation side to learn what the other one does and how they can positively impact the patient, so we can close that cancer rehab gap.
Very good. Very, very good. Well, Leslie, this was a spectacular overview in our 2-part series that we put together. I just sincerely hope that cancer center administrators, med-oncs, rad-oncs, surg-oncs are watching this. Frankly, patients are watching it, other physical therapists. I think you've shared with me that a lot of physical therapists coming out of their training just have a little bit when it comes to cancer rehab. And hopefully this is going to be motivating people who are physical therapists right now to learn more about the actual cancer rehab part. Now, before we wrap this up, I want you to share with the audience what the Waltke Cancer Rehab Academy is.
I have, like I said, I've been a physical therapist for 32 years, spent most of that in cancer care. And I have some fantastic colleagues across the country that specialize and have dedicated their lives to oncology, but there's just not a lot of us out there. So it's been well over a decade now. I developed the Waltke Cancer Rehabilitation Academy, and we do 3 things. We educate both physicians, nurses, that side, and we do continuing education courses for physical therapists and occupational therapists. And then we help build cancer programs. Like you can either be a phone conversation, this is what you do, or we literally come in and, step by step do it for you. And then we also have just consulting, where we just kind of answer questions and help people develop ideas and answer, problem solve. So we have we basically develop programming for whatever our customer needs, with the goal of improving patient care, improving patient outcomes.
And if people want more information or want to get a hold of you, what's the best way to do that?
The easiest way is to go to waltkeacademy.com is our website, and the website, you can get a hold of me there. Otherwise, my email address is info@waltkeacademy.com. I'm easy to get a hold of, and would just be very, very happy to talk to people.
Oh, that sounds great. Well, let me take this opportunity to wrap this up. This has been a two-part series. It has truly been my honor and privilege, Leslie, to be working with you on this two-part series. I think the information that we have provided everybody has just simply been outstanding. Let me thank you for the opportunity of working with you. Here's wishing everybody, as I'm sure you will as well, all the best, and stay safe. And thank you for the privilege of your time.
Yeah, my pleasure. Who would have thought that in the middle of a Wisconsin day that I'd be having to move my chair to get out of the sunlight? That just doesn't happen around here too often. So, but thank you again, Dr. Harness. It's a pleasure. And I'm hoping that this is very impactful to our physicians and practitioners around the country. Thank you.
Oh, you're welcome. It's been my privilege. And thank you, everybody.